Hello, and welcome to the lecture on maximizing comfort for the laboring woman. So some learning objectives for this lesson include identify non-pharmacologic strategies, including breathing and relaxation techniques used to enhance relaxation and promote comfort during labor and birth. Compare the pharmacologic methods used to relieve discomfort in different stages of labor and for vaginal or cesarean birth. Discuss the effects of medication management for mother and for the newborn both during labor, during and after birth. Construct an evidence-based plan to manage the discomfort that a woman experiences during childbirth. Explain the nurse's role and responsibilities while providing care for a woman receiving analgesia or anesthesia during labor. Describe the nurse's role in promoting comfort and safety throughout labor and birth process. So pain during labor and birth. We have to remember that pain in labor is a normal physiologic finding. Most women are going to experience some degree of pain during labor and the birthing process. So there are some origins that we want to discuss that occur within certain organs that contribute to labor pain. So visceral has to do with internal organs. Referred pain is away from the pain stimulus. In other words, women may feel painful contractions in their lower abdomen, and that pain may radiate down the top of their thighs or into their back. Somatic pain originates in soft tissue. So every woman's perception of pain during labor and birth can be different. Some women may view pain as a very painful process, and other women may view pain as a work that their body's accomplishing to produce a new life. Expression of pain can also vary during labor and birth. Some women may not experience or express much discomfort, and they may just breathe through contractions. They may be very quiet or stoic, where other women may be very, very vocal and pretty much out of control during the process. So factors that influence pain response. So there can be a lot of these. So we got physiologic factors, cultural, anxiety, previous experience, gait control theory of pain, comfort, support, and environment. And it can be one of these or many of them that can contribute to the way a woman responds to labor. For example, if she had a very traumatic childbirth experience with her first labor or one of her labor experiences, she may go into the current labor situation very anxious and have kind of a post-traumatic stress response to that labor before. It's important to encourage women to discuss these things. And it's important to also get an idea of what a woman's plan for pain management might be when she presents. Now, the gait control theory of pain, we're going to talk about that a little bit more detail, but this is basically creating another stimulus of some type to distract the woman from the labor pain. Non-pharmacologic pain management is a really important component of labor management and pain because we want women to be able to have those resources to fall back on, because pharmacologic methods, while they can be very helpful, a lot of times pharmacologic methods don't work, or they don't work the way the patient may think they're going to work. Okay, so childbirth preparation is really important. They have to anticipate labor is not going to be a comfortable process. We want them to focus on relaxing and breathing and using breathing techniques, especially between contractions. We want them to relax and focus. And then while they're having a contraction, breathing through that contraction. And they want to focus on breathing in deep breaths and not hyperventilating. Effleurage and counter pressure are very important techniques. Effleurage or massage, you can massage just about any part of the body on the patient to help with comfort. And counter pressure, it's squeezing the patient's hips and back, rubbing the back at the pelvis to help with back pain. And so counter pressure is important. We can also teach the partner that they can help with these techniques. touch and massage. Again, a Fleurage massage can be very therapeutic for patients. Although if they are experiencing the transitional phase of labor, a lot of times patients may not want to be touched. So again, it's important to talk to patients to find out what they need at that moment in time, because we don't want to just assume that's what they want when they really don't want to welcome any kind of touch. Application of heat and cold. So sometimes warm packs to the back may be very helpful for women with back labor. Other methods of non-pharmacologic pain management include acupressure, acupuncture. We've seen women use this who are doing a natural labor, who kind of have this in their birth plan. We talked about the gate theory, and that's part of that can be the TENS unit, or the transcutaneous electrical nerve stimulation. Water therapy is probably one of the most therapeutic non-pharmacologic methods that we use. So soaking in the bath, or a warm shower, or even just running warm water over their belly. Intradermal water block is also known as a sterile water papule injection, where there's 4 points on the patient's lower back that we inject sterile saline just under the skin, and that's thought to help with back labor. And then aromatherapy is another one where they may use essential oils to help them relax. Music, hypnosis, and biofeedback are other methods that women may include. And this is just showing you a patient using water therapy. The patient there on the right is probably using a Bluetooth or a fetal monitor that can be submerged in water, where the patient does have that liberty to move around in labor. More and more labor and delivery units are getting this method of fetal monitoring, so the patient isn't strapped to the bed and strapped with cords hooking to a monitor, so they can have more mobility in labor. And we're going to talk about position change, because position change and mobility in labor is really essential in pain management. So moving on to pharmacologic pain management, so there's a variety of things that can be used. Nowadays, we're not really using much anything for active labor other than fentanyl, which is an opioid. So we're using that for contraction pain once the patient's in labor. And the reason why we switched to fentanyl is because fentanyl has a short half-life. It doesn't really affect the neonate. Some of the other opioid injections we used to use, like Demerol, and then we'd also add Phenergan to that, would really cause a lot of sedation in the newborns. So we've really moved away from those medications. So sedatives may be used to relieve anxiety and induce sleep, typically used for women in a prolonged latent phase of labor. So remember, when they're in the latent phase, they're not actively dilating their cervix. However, these women can have a lot of discomfort and a lot of pain, but they're not progressing. And so they can become very tired because they feel like they're in labor, but they're not progressing. Especially women who are under 39 weeks, where we can't really help them out. We can't give them Pitocin. We can't initiate labor. They kind of have to do it on their own. So it can be difficult for these women. But therapeutic rest is something that we utilize. And we need to be sure that they're far enough away that they're not going to be in active labor. So if they're 2 centimeters and they're not effaced, their cervix is very, very thick, that patient would be a really good candidate for therapeutic rest, because we know by the time she goes into active labor, the medications will probably wear off. And we usually give them in the form of like morphine. We'll give them like a 10 milligram injection with some Phenergan to help them sleep. Vistaril is another really good medication that we use for therapeutic rest. Sometimes they'll come to OB triage and they'll just be really exhausted, in a lot of pain, and we'll give them like an Ambien to go home with, or we'll tell them to take some Unisom. Because these women oftentimes are not getting enough sleep, and that's going to help contribute to the problem if they're not sleeping enough. And so this will enable the woman to rest and get some sleep, and hopefully she'll wake up and either be in labor, active labor, or her contractions will go away. We don't really use these medications so much anymore, barbiturates, phenothiazines, benzodiazepines. These drugs are often very sedating and can be very addictive, so we try to avoid those. Ambien can also be addictive. If we give it a one-time dose, we usually have the patient take it as long as they have somebody to drive them home. That is fine, and we just give it as a one-time dose. Other pharmacologic management for pain and labor. Okay, anesthesia encompasses analgesia, amnesia, relaxation, and reflex activity. Okay, so this is usually going to be in the form of an epidural for labor. Analgesia, so again, this is going to be alleviation of the sensation of pain or raising the threshold for pain perception without loss of consciousness. So that's going to be our fentanyl. And so we give that IV push. The dose is usually going to be 50 to 100 micrograms. And usually we inject it very slowly when the patient's peaking a contraction. And then it helps her relax. Now, fentanyl will usually last them probably like 45 minutes to an hour because, again, we're giving an IV push. Now, 100 micrograms is usually what we want to give these patients because 50 is not going to do much for labor pain. So we do have to tell patients that many patients won't experience the same therapeutic effect if they're receiving multiple doses because fentanyl can be given every hour while in labor. But they kind of build up a tolerance and then they don't feel like they're getting any relief. So if they really want long-term pain management and they have a ways to go in their labor, an epidural is really the way to go. So systemic analgesia, so again, we talked about this. We really only use fentanyl for this, which is an opioid. Okay, nerve block analgesia or anesthesia. So again, this is going to be mostly the epidural. Local perineal infiltration, that's typically used for the repair after the birth. It's not really used for pain management and labor. But if the patient has a good epidural, oftentimes we can use the epidural to perform the repair if needed. Otherwise, we do the local infiltration of like 1% lidocaine. Before we do a repair on their perineal area or vaginal area, whatever they need repaired. Pudendal nerve block is not really used much. I've only seen that once in my whole career. And that's where they numb the pudendal nerve. They use a really long needle because it's at the very back of the vaginal canal. And they put in anesthetic to provide a nerve block for the pudendal nerve. And it just helps decrease the sensation of pain as a baby's head is coming through there, but we don't really use it anymore so much. And then spinal anesthesia is usually used for a C-section, and they won't really get a spinal unless they have a scheduled C-section. Otherwise, if they're laboring and they have to end up going for a C-section, they'll just bolus the epidural and make them numb enough so that they don't feel the surgery. They can get a post-dural headache from the puncture. Okay, so this is where usually with an epidural, because that needle gauge is going to be a little larger than with a spinal needle. And what they do is they go too far, they go a little bit too far past the epidural space and into the spinal column where the spinal fluid is. And if they puncture the spinal fluid and it's a big enough hole, it's going to leak out. And so this leaking of spinal fluid is what causes the patient to get a spinal headache. Now, classic sign of a spinal headache is going to be the patient sits up and they get the worst headache that they could ever imagine. If you lay the patient flat back in bed, the headache disappears. So that's how we know they have a spinal headache. And no ibuprofen or any narcotic is going to make the headache improve. Okay, so it's important to understand if your patient has a spinal headache because there's only one of two treatments that can occur. One, they either have to just let it go away on its own. It's going to take a few days for that that to heal up so that spinal fluid isn't leaking. Another procedure they can do is called an epidural blood patch. What they do with this is they draw the patient's blood in a syringe. They sit the patient up just like they're going to place an epidural, same type of procedure, and they inject the blood into the patient's back. And that's supposed to plug up the hole where the spinal fluid is leaking because it creates like a blood clot or a patch, if you will. So that's what helps plug up that hole to prevent leakage, and usually the patient feels much, much better if it works. Sometimes it takes a couple attempts to do that, but it can really help the patient. Okay, nerve block, analgesia. So again, we talked about epidural. We really pretty much do an epidural. And once they get an epidural in, they don't get up. Okay, so we don't really do a walking epidural or combined spinal epidural. It's very rare to see that. I did put it on here because it does exist. And so sometimes, very rarely, you may see this. But again, it depends on the anesthesiologist who's performing it as to what they're doing. To give the patient a block. Okay, and this is pretty much how the patient's positioned. They're either positioned in the fetal position. I've kind of seen it more nowadays where the patient is sitting up and curling their back. And usually what we do is we have them sitting straight with their knees on the side of the bed. And then we have them roll forward and slouch, drop their shoulders, roll forward, and we tell them to make their back like a shrimp or a Halloween cat so that they really open up those spaces. And then they need to hold that position so that the anesthesiologist can get the epidural in between the vertebrae. Because if they're too tight, they can't get in those spaces. And then they numb up the back with local anesthetic, usually a lidocaine. And then they put the bigger needle in through and puncture the epidural space. And then they kind of use a syringe and keep pushing on the syringe until it goes, there's no resistance. And then that's how they know they're in the epidural space. They do something that's called a test dose, where they give the patient a little bit of medication through there. And they'll ask the patient to let them know if they're feeling any ringing, if they're hearing any ringing in their ears. They have a metallic taste in their mouth, their legs suddenly go numb. And then we make sure that we put a pulse ox on the patient's finger and that they have a blood pressure cuff on. If they get tachycardic, that's a good indication that the patient is experiencing a reaction, because they get very tachycardic, and usually that means that they hit a blood vessel. And they have to pull it out and start over again. Okay, so contraindications is subarachnoid and epidural blocks. So this is just basically anything going into the patient's back. If they have an active or anticipated serious maternal hemorrhage, maternal hypotension, maternal coagulopathy, infection at the injection site, increased intracranial pressure, allergy to the anesthetic drug, maternal refusal or inability to cooperate. So again, patients are having contractions and they're uncomfortable. And oftentimes, if they're moving all around the bed or they're moving, they can't hold still, they can't place the epidural. So as a nursing role, it's important to kind of help our patients manage their contractions while they're getting the epidural so that they're able to sit still and allow the anesthesiologist to place the block. Some types of maternal cardiac conditions, it's contraindicated. And then the main things that we typically see is if they have coagulopathies. Okay, if they have low platelets or some blood clotting disorder or bleeding disorder, it's mostly going to be a bleeding disorder where they can't really place the epidural. Maternal hypotension, we bolus the patient with a liter or two of LR before we even do the procedure, because we do anticipate the patient's blood pressure is going to drop and they're going to get hypotensive. It's the number one side effect of an epidural. And if the patient gets hypotensive, then we're going to have a fetal heart rate deceleration. Because if you remember, perfusion is going to be affected by hypotension. Okay, so we want to make sure that patient's nice and hydrated. We have to get CBC results back or hemogram results back that show the patient's platelets before we can place the epidural. And the anesthesiologist will want those results before they'll even come and place the epidural. Okay, so this is kind of what it looks like, where they put the needle in through the spaces in the spinal column, and then you can see the medication being injected in there, and that's the epidural space right there. Okay, but beyond that, the spinal cavity. So if they're getting a spinal, they go a little bit further into the spinal column. And again, it's a much smaller needle. And then a catheter is threaded through that needle and sits in the epidural space and delivers the medication to the patient on a continuous infusion. They can also give them like a PCA, where they can hit a button to give themselves a little extra bolus of medication. And then, of course, there's a lockout. So a good thing to do is ask the patient where they're feeling the pain. You know, if they're hitting that bolus button a lot, they probably are not. Their pain isn't really being managed too well, and so the anesthesiologist can always come and give them an additional bolus, okay, of medication. Sometimes what might happen is the patient may feel the contractions on one side, so it's really important when you lay the patient down after the epidural is placed that you lay them kind of on their back and kind of a little bit of a semi-Fowler's, because what happens is if you lay them on their side, epidural medication works with gravity, so it's going to run to that side that they're laying on. So if they're laying on their left side, they're going to get most of the medication. So it's important to let the epidural set up for about 20 minutes, and then you can kind of move your patient. We don't really want them flat on their back. That's why we kind of raise the head of the bed just a little bit, but we do want that block to set up evenly, so that's why we lay them that way. Okay, nitrous oxide. I mean, I know up here in Reno, we don't really use a lot of nitrous oxide. We tried to get it. It just seems like a really difficult thing to get. They may use it maybe down there. Where you guys are, there's more hospitals down there. So you can let me know if they use nitrous there, but it's a really great option. If they can't get an epidural, there's a contraindication for an epidural, or just if the patient doesn't want one, but they want a little bit of relief and to get the edge off the pain. Okay, so what it is it's mixed with oxygen. It's kind of just like they get at the dentist's office. It's laughing gas. It's inhaled in a low concentration to provide analgesia during the first and second stages of labor. And the great thing about this is a baby really never sees it, because once the patient breathes it in, it's very temporary during a contraction, and then they take the mask away. There's a little bit of a reservoir where so it doesn't go throughout the room, that collects the gas that she exhales. And so that's pretty much how it works, is they bring the mask to their face, so it's patient controlled. They breathe it in during a contraction, and then they let go. And usually what happens is they still feel the contraction, but it makes them not really care about the pain. So they're just kind of like, okay, they bring it to their face, they breathe it in, and then they let go. Okay, so it's a really, really nice option for the patient. I wish that we had more of it. Okay, so they should be pre-medicated with an oral antacid to neutralize the acid contents of the stomach. So it can make them nauseated. Because of the risk of neonatal narcosis, it is critical for the baby to be delivered as soon as possible after the induction of general anesthesia. So sorry, we're talking about general anesthesia. So that's something that we try to avoid doing. If they're a true emergency crash patient, such as they come in, they have a category 3 tracing, and they need to be delivered ASAP, we will put them under general anesthesia. Okay, so again, we do try to pre-medicate them. And so the medication we use is called Vicitra. It's a drink that they drink down. It's very, very sour, so we tell them to drink it really fast. Usually they get it even if they get a spinal. They get pre-medicated usually with Vicitra, Pepcid, and Reglan. And so those two medications are given IV because the anesthesiologist wants their stomach as empty as possible. These patients also need to be MPO for 8 hours. So if the patient was supposed to have a scheduled C-section and they came in and they told you they just ate, they're going to bump their case. Okay, so that's usually what happens. Unless they're a true emergency, but there is a higher risk of aspiration with general anesthesia. So again, we try to avoid putting the patient under. Okay, so the care management for the non-pharmacologic intervention, ask them how she feels to evaluate the effectiveness of specific pain management techniques used. And then we use a pain and or coping scale. And I think with labor patients, a coping scale is actually more reasonable because again, pain is really a normal part of labor. Okay, and it's just dependent on how the patient perceives it. So are they coping with the contractions? Okay, are they breathing through them? Are they working with them? Or are they out of control? So that's something that we should make a note of. Okay, care management for pharmacologic interventions. Okay, so again, general informed consent. So with an epidural, the patient will sign a consent form. The anesthesiologist needs to come in and talk about the risks and benefits of the procedure. Okay, so, and this is true for anesthesia with a spinal prior to the procedure. Timing of administration. So again, it's important to discuss with the patient what's their plan for pain management. And if they desire an epidural, it's important to let them know that they need to tell you as soon as possible if they want that, because A, they have to get the fluid bolus in, and B, they have to get the lab results back. Usually labs are drawn on admission, and so, you know, if it's a little bit ways away from the time they were admitted, they'll have the lab results, but if they come in and they're in labor and they're requesting an epidural, they have to be aware that they need these things back. Also, it depends on availability of anesthesia. If they're in a C-section, you know, the patient's not going to get it right away. So again, it's important to discuss these things with them. Preparing for the procedure, so letting them know the positioning and how they should be during the epidural. Administration of medication, so again, is it intravenous, intramuscular, regional, and then again, you know, the fentanyl is going to be mostly, it's going to be intravenous, and then we usually rarely give intramuscular route, although we have done therapeutic rest medications, IM, and then of course regional is going to be your epidural or spinal, and then safety and general care. Again, having the patient hold still during the procedure. So key points, non-pharmacologic pain and stress management strategies are valuable for managing labor discomfort alone or in combination with pharmacologic methods. The gate control theory of pain and stress response are the basis for many non-pharmacologic methods of pain relief. The type of analgesic or anesthetic to be used is determined by maternal and healthcare provider preference, the stage of labor, and the method of birth. Sedatives may be appropriate for women in prolonged early labor when there is no need to decrease anxiety or promote sleep. When there is a need to decrease anxiety or promote sleep or therapeutic rest. Naloxone or Narcan is an opiate narcotic antagonist that can reverse narcotic effects, especially respiratory depression. And again, with these medications, we very rarely see that. We probably use more Narcan on the newborns rather than the moms. Just because they would wake up very, very sleepy from the medications. And that's why we tend to stay away from those other ones and stick to more like fentanyl. Pharmacologic control of pain during labor requires collaboration among healthcare providers and the laboring woman. The nurse must understand medications, their expected effects, potential side effects, and methods of administration. Maintenance of maternal fluid balance is essential during spinal and epidural nerve blocks. Maternal analgesia or anesthesia potentially affects neonatal neurobehavioral response, which again, we're seeing less of that now. The use of opioid antagonists and analgesics in women with pre-existing opioid dependence may cause withdrawal symptoms of abstinence syndrome, so opioid withdrawal. So this is really important to point out if a woman does have a substance abuse problem with opioids. And you may want to go more for the epidural in that case because it can affect them. Again, obtaining a really good history is super important to be able to identify this. Epidural anesthesia and analgesia are the most effective available pharmacologic pain relief methods for labor. They are used in the majority of women in the United States. General anesthesia is rarely used for vaginal birth. I mean, we don't ever use it for that, honestly, but it is used for cesarean birth whenever rapid anesthesia is needed for an emergency childbirth situation. So here's a question for you. A woman in labor has just received an epidural block. The most important nursing intervention is to, so think about this question for a minute. And your answer for this is going to be C. It's to monitor the maternal blood pressure for possible hypotension. Because remember, this is the #1 side effect.